Good evening, one and all. It gives me great pleasure to welcome you all to this special educational webinar meeting. Without wasting much time, I hand over the session to my co-moderator, Dr. Shantanu, to introduce Nitin Barkule.
Thank you, Dr. Manivasagan. So it's indeed a pleasure to introduce Dr. Nitin Burkle. He's the past president of Indian Academy of Echo and a great multimodality imager. He is going to give us some insights about the use of cardiac CT, how is the hardware and how is the image display. Over to you, Dr. Nitin Burkle. Please, let's share your screen.
Thank you, Dr. Shantanu and Dr. Manivasagam. I will share my screen. Yeah. Is it visible?
Visible.
Visible. Okay. So let me just say one line that unless we know the physics of ultrasound and the instrumentation of our echo machine, we cannot acquire the images well, neither we can interpret them well, and neither we can find the artifacts. Similar thing is about our other multimodality cardiac imaging, that is cardiac CT and cardiac MRI. We should know very basic physics and instrumentation. So this is a series of lectures on cardiac CT, and the first one is instrumentation and technique.
Dear friends, let us discuss the cardiac CT, instrumentation and the different techniques. It was in 1971 that Dr. Hounsfield invented the clinical CT, and on 1st October 1971, the first patient was scanned. He was awarded the Nobel Prize in 1979 for medicine and physiology. In his Nobel speech in 1979, he said, "A further promising field may be the detection of coronary arteries. It may be possible to detect these under special conditions of scanning." And that has really come true in this particular era. So what are the special features of cardiac CT or the coronary CT? First is that the challenge is that we are looking at small structures, the coronaries, which could be anywhere from 2.5 to 3 millimeters. We need a very good spatial resolution so that we get a data as good as the fluoroscopy. Secondly, you need a very good temporal resolution because the coronaries are constantly moving with cardiac cycle. We need a very good ECG synchronization, and the way the CT captures the images, we have to cover the entire volume data set of the heart from the base to apex. The CT technology progressed really fast. In 1998, we had 4-slice CT scanners. In 2021, we had 16 slices. In 2004, we had 64 slices. Now the 64 slice becomes the workhorse for coronary CT. And in 2007, we had even 320 slice CT, making acquisition of the heart in one single heartbeat possible. Let us look at the CT hardware. The CT scanner has got an X-ray tube, a filtration device, and then the collimator. And on the opposite side of the gantry, you have an array of radiation detectors. These detectors convert the X-ray attenuation values into digital signals. Let us go into more details of this. This is how the CT gantry looks like. And this is the X-ray tube, which creates this fan beam of X-rays, which pass through the patient who is lying in the gantry. And on the opposite side, we have an array of 800 to 1000 detectors arranged in a row. And these are the ones which actually measure the attenuation value of each of these X-ray in this fan X-ray beam. To make the coordinates the same, let us say the shoulder to shoulder is your x-axis, your sternum to back is y-axis. and head to foot is z-axis. So z-axis is the direction in which the scanning continues as the patient's table moves into the gantry. So what is single slice and what is multi-detector CT? Now a single slice CT or a multi-detector slice CT, if we look it in a z-axis, then the single slice CT has got the X-ray fan beam and only a single row of detectors on the opposite side of the X-ray tube. While in a multi-detector CT, in the head to foot direction, you have 16 or 64 or even 320 detector rows. So what happens is that actually your X-ray fan beam in your X to X and Y direction, in a Z direction, it gets spread out, and the X-ray fan beam, you can call it now an X-ray cone beam, because now in one gantry rotation you can cover a large sector of the patient for imaging. So when you have got 16 detector row, or when you have got a 64 detector row, you call it a 16 slice CT or 64 slice CT. The the X-ray gantry rotates like this. If you remove the hood, you would see that the X-ray tube and the detectors on the opposite side make the rotation around the patient really fast. So most of the modern scanners will finish one rotation in as early as 0.3 seconds. That is just in 300 milliseconds. This is what actually goes on under the hood. If you showed this to the patient, next time the patient will not enter the gantry. So the thing is, so this is how the scanners are, and this is the row of detectors, and this is the X-ray tube. And what has made the CT scan technology possible is because of a technological invention called as the slip ring technology. Now, what is a slip ring? Slip ring technology is actually an electromechanical device which is at the interface of the rotating gantry and the stationary component of the gantry. And what it does is that it seamlessly transfers both the electrical current for the X-ray tube and also the electrical signals from the detectors to the stationary outer shell of the CT scanner. So that is why you don't need any wires going into the gantry. Otherwise, the kind of gantry rotation you had just seen, all your wires would have got entangled. So this slip ring technology has made it possible to seamlessly transfer the data from the detectors to the outer console, and so also get the electrical energy to the rotating X-ray tube. So if we look into the actually the X-ray tube, this is how it is. So we have this cathode, and this cathode emits the electrons. These electrons strike the anode, which is generally made of tungsten, and this anode is continuously rotating. When this electron beam strikes the anode, it creates X-rays, and these X-rays are then passed through the patient's body to create an image. The X-ray tube needs certain characteristics. One thing is that it needs a large, high frequency power supply and a very stable current and voltage to create these X-rays. So voltages are typically in the range of 80 to 140 kilovolt, and the current that the CT scan X-ray tube consumes is up to 1000 milliamperes. So the radiation dose that you can calculate is by milliampere second. That means the current that is flowing through the X-ray tube multiplied by the duration for which the X-ray tube is on. So that is the amount of radiation that the patient gets is called as milliampere second. The anode is always the anode is always perpendicular to the electron beam, and the X-ray tube is always perpendicular to our image plane. That is the axial cut that you have in the patient's image. Now, this is done to have a very uniform radiation passing through the image slice. The anode, which is this rotating anode, which actually creates these X-rays by absorbing the electron energy, has two jobs. First of all, it converts the electrons into the X radiations, plus it has to dissipate the heat fast, and it should not melt at high temperature, it should not evaporate. So it is made of a high atomic number like 74. So most of the time it is tungsten. The X-ray spectrum, if we see here, as you increase the energy, the characteristic X-rays are very high powered photons, are very high powered photons, and those can penetrate through the patient's body. So the thing is, the X-rays that are created may not have a very uniform energy. So what you typically need is a copper or aluminum filter. Now this copper or aluminum filter, what it does is that it removes the low energy photons so that only high energy photons of the X-ray can cross the collimators to enter the patient's body. So remember, the CT X-rays are highly filtered and very high energy photons. So that is why they have got such a good penetration. This also reduces the beam hardening artifact, which we will be discussing at the in the next lectures. After the inherent filter, there is another filter called as O-type filter. It is made of Teflon. It is thinner in the center and thicker at the edges. So what it does is that it allows the high energy photons to pass in the center of the fan beam or the cone beam, while reduces the energy at the periphery of this of this cone, of this X-ray cone. Now, why does it do that way? Because whether it is head or whether it is the abdomen or the cross section of the body, you will have thickness in the center. So that is why if you have got a higher energy photons, X-rays coming in the center of the beam, okay, you will have a uniform output through the at the other end of at the detectors. So that is how the bow tie filters can compensate for the increased thickness in the center of the body or the brain. The next thing is the collimators. So when this highly filtered X-ray beam travels towards the patient's body, you have got collimators, the same way that you have in the cath lab. These collimators will prevent the scatter of radiation. And these collimators have got a different purpose. When you had a old single slice scanner, then how thick or thin was the collimator aperture? It used to define the slice thickness of your image. But in multi-detector CT, it just defines the thickness of the X-ray beam in a Z direction, that is head to foot direction. However, the thickness of the slice is determined by the number of detectors which lie in the Z axis. So if you have got detectors which are of 0.5 or 0.6 millimeter thickness, then your slice thickness can be 0.5 or 0.6 millimeters, or you can add up the data of the neighboring detectors and can make thicker slice also. So that means in the current CT scanners, the slice thickness is a post processing. You can make the slice thickness thinner or thicker depending upon how you use the data from your 64 slices or your 64 detector array. So that is how you the thickness of the slice depends upon the reason for which you are doing the imaging. You can that is how you decide about the thick or the thin slice. So the collimator's width reduce the scan time if it is a very large width, because then you will cover more area. But then it also reduces the scan time. But problem is that if you made a very thick beam, you can have partial voluming. It does not change the radiation dose at all. Now let us look at the detectors which actually create the image. Okay, so the detectors lie in the z-axis direction. Okay, and this is the row of detectors, and each element is a one which decides the thickness of your slice. So when you have what, so the detector element, their thickness in the z direction is around 0.5 to 0.6 millimeters. So when you have got a 64 rows of detectors in a 64 slice CT in the head to foot direction, you can cover almost up to 40 millimeters of the patient's body, okay, in one gantry rotation, okay, to create the images. So that is how it is. So you have got if a 64 detectors in this direction, you will cover 40 millimeters. So that is 4 centimeters. Okay, and generally, as you know, for the heart from base to apex, you will have anywhere from 12 to 14 to 16 centimeters to cover. Okay, so that is how you may need such kind of 3 volume data sets to cover the entire heart. So what does the detectors do? So what happens is that the X-rays pass through the body and then come and then strike the detectors on the opposite side. So each ray is the one which carries the information of the energy attenuation. So these detectors are nothing but scintillators. So what they do is that when the X-ray beam falls onto them, they scintillate and create light. And this fluctuation of the light and the light intensity creates the analog signals, which are then which are picked up by the photomultiplier tubes or photodiodes, and then that is converted from analog to digital to get the digital data. Okay, so that digital data carries the information from each detector about the attenuation value of that X-ray beam. And they are very these detectors are very quick in their temporal response to X-ray to create the light. They do not have afterglow and they rapidly decay, so that you get a very good analog signal. So let us look at the how the image is displayed by the multi-detector CT. So again, we'll go back to our X-ray cone beam. So this is our X and Y direction of the shoulder to shoulder and the spine to sternum direction, and this is the Z direction, which is the direction of head to foot, and our 64 slices or 128 slices or 320 slices are in the direction of the head to foot. Okay, so more the number of detectors in the Z direction, or more the number of slices, you will cover the heart much faster. So as we can see it in relative terms, when you have got a 64 slice scanner, you cover around 40 millimeters. Your 120 slice scanner will cover 80 millimeters or 8 centimeters, and the this next generation 320 slice scanner can cover almost 16 centimeters. So it is just one go around the heart and you have covered the entire heart in just one rotation around the heart. So you can really have a single bit acquisition. But most of the places will have 64 slice CT, and that's the workhorse for CT coronary angio. So we should know how the images are created by this 64 slice CT. So let us come to this question. How many detectors are there on the opposite side of the X-ray tube in your CT gantry? If it is a 64 slice CT. So it is actually 64 rows, and in each row around the perimeter of the gantry, you can have 800 to 1000 elements. So this is the number of elements you have in your detector panel, and that creates a huge amount of data, because each of these detectors is going to cause a scintillation when the X-ray beam falls onto them and create the analog and then the digital signal. So this is how the X-ray tube will fire the X-ray cone beam. It will go through the body, and this is where we are having the detectors. So this is called as a projection. That means the position of the X-ray tube on the perimeter of the gantry is called as the projection. You can have 1,000 such projection along the 360 degrees of the gantry. Then each X-ray beam which travels from this X-ray tube to a single detector element is called as a ray. So that is a ray, and this group of all these rays at this particular position of the X-ray tube is called as projection. So you have got 1,000 projections, and each projection will have 64 into 800 elements or rays. So remember that amount of data you are creating. So the so when you are having a particular projection along the perimeter of the gantry, whether your position is here or your position is here, the detectors on the opposite side create an attenuation map, because some of the X-rays, the rays, that means the X-ray beam from the X-ray tube to one single detector element, okay, its attenuation value will be plotted here. Okay, so when you have got a high attenuation, you have got lower values here. When there is hardly any object in the path of the ray which can absorb the photons, you will have a less attenuation. Okay, so that is how from thousands such points you are going to create these kind of attenuation maps. Okay, and each projection is going to have its 64 into 800 elements or the rays, and for a 64 slice CT. So the thing is, when you are constructing an image, you are going to take account of all these projection data when the gantry moves around the patient's body. Okay. So the thing is, so this particular projection and the attenuation data that you get is measured in Hounsfield unit. So this Hounsfield unit is the surrogate for the linear attenuation that happens, the linear attenuation coefficient. So how do you calculate the Hounsfield unit? So this Hounsfield unit, also called as a CT number, is actually the linear attenuation coefficient through, say, bone, or through, say, muscle, or through, say, lung, or through, say, metal, in comparison or relative to water. So the Hounsfield unit is always measured in comparison to water. So the thing is, the water is given Hounsfield unit is 0. Okay, so you can have the Hounsfield unit values above the water or less than the water. So this CT number or the Hounsfield unit of the different tissue depends upon the density of the tissue. Like the bone will have very high density, the atomic number of the molecules which constitute that tissue, the photoelectric energy, and the electron density. So if water is 0, then the air is in minus. So air can be anywhere in minus 1000. The bone is in plus. It can be plus 1000. So if we put all the Hounsfield values from plus 1000 to minus 1000 with water at center, that is 0 Hounsfield unit, then you would see that most of our tissue would lie between minus 100 to minus to plus 100, minus 100 to plus 100. So the fat is less than water, so it is so fat comes to around minus 90. The lungs obviously have air, so they will be somewhere on minus 750. The air is minus 1000, while the muscles would be plus 25. The blood is around plus 55, liver is plus 60, the brain is around plus 35, while the bone, depending upon which type of bone it is, can be anywhere from 500 to 1000. So that is how the grayscale would be distributed. So that is why if you see a fat on the CT, it would be having the blackish to overtones, blackish tones. Okay, while you will see the muscles which look more grayer than the water. Now the thing is, we have to also consider the dynamic range, because you are collecting so many Hounsfield unit data from this cross section, and if you spread that entire Hounsfield units from minus 1000 to plus 1000, that means 2000 values over 256 or 128 gray levels, then you will hardly have any contrast in the image, for the simple reason that, as we saw in the previous slide, that most of your soft tissue is between minus 100 to plus 100. So there will be hardly any discernible difference between the heart, the liver, and the muscles, or so on and so forth. So that means we will have to decide a range of Hounsfield units, and we have to display that range into 128 or 256 gray levels. The same thing that you do it in the echo, the dynamic range of ascribing the grayscales to different levels of decibel values. So here you are ascribing them to the Hounsfield units. So let us look at this. Let us look at this. Suppose if we have distributed from minus 1000 to 2500 Hounsfield unit, all the 256 gray scales, and this is 0, which is water, which is the mid range of the gray. Then this 0 is called as window level. That means the center of the grayscale is called as window level. And what is window width? The values in between, you have spread up the grayscales, like minus 1000 to plus 2500 is your window width. So window level and window width. So remember, window level is the center, the Hounsfield units which form the center part of your grayscale, and window width is the extremes of the Hounsfield units. So they will be either extreme white or extreme black. So now suppose we can always change this window width and window level. And how do we do that? As we can see it here, that if we are having this level of window level and window width, we can also take the window level down or up, or we can also expand the window width. Okay, so we can do these things. We can decide our window level to which we are going to give the mid level of grayscale at what Hounsfield unit. We can decide the window width, that is the range of Hounsfield units that you are going to ascribe the grayscales, and also you can change the window width. Okay, so this is how you can use the data. So that is how you can use this window level and window width to bring out the contrast, either for the bone or for the lung or for the soft tissue. So if we see the same thoracic cross section, when you had a very wide window width, okay, and when you have got this particular window level at 0, you have an image something like this, where you can hardly make out the heart. While when you have reduced the window width to 400 Hounsfield units, and kept the window level at 0, then now you can discern the mediastinum, the heart muscles, the sternum, the fat, and the muscles. Okay, and as we said that the fat is going to have lower Hounsfield units than water. It looks having blackish color. Okay, so it will have the grayscales going towards black. So always remember the fat in a CT image will be going towards the blackish shades. So the same image now, if we make the window level at minus 593 and the window at 529, now you do not, you see the lungs so well, but you don't see any tissue differentiation in the mediastinum, neither in the chest wall. Okay, but you can see, but as since we have taken the window width towards the air, we are seeing much better the pulmonary arteries and the bronchograms.
Okay, so this was the overview of the city technique, and I think what we would be doing is our next lecture series, we will be talking about how the images are acquired by the CT scanner by the gantry rotation. Okay, so all that spiral scanning and everything we'll discuss in the next lecture.
So do we take the questions now or anything in the chat box? I think once we have questions, maybe I can ask you later on. But let's move on to the next topic. That's yeah. So is Dr. Rohit Tandon will take it?
Hi, good evening, sir.
Yeah. Hi, good evening. So let me introduce Dr. Rohit. Rohit is a great friend and a great imager. He's a consultant cardiologist working in Ludhiana, and he's going to speak something which is a very important topic about mitral valve collapse. What are there any misconceptions about identifying this? Over to you, Rohit. Please share your screen.
Thank you, sir. I want to share my screen. And can you tell the person?
Press the green button, share.
Okay. Yeah.
Then you have to click on your presentation.
Have you downloaded your presentation? Yeah.
Yes, sir. I hope my screen is visible to all.
Yeah,
Yeah.
we can see
Yeah.
that. Yes.
You can
Okay.
enlarge it now.
Yes, sir.
Perfect. Perfect.
Yeah. So, mitral valve prolapse, my objectives of my presentation today are like the diagnostic criteria for mitral valve prolapse, the definition and terms associated with mitral valve prolapse, which modality is better and which view is to be taken, preferably echo. The whole presentation is mainly focused on echocardiography. Mitral regurgitation evaluation, that's another challenge in presence of mitral valve prolapse, and incorporating new technologies like 3D echocardiography and the concept of arrhythmogenic mitral valve prolapse. So to start with, mitral valve prolapse is classified based upon the anatomical and physiological defects responsible for the abnormal leaflet motion. It is divided into primary mitral valve prolapse when the valvular abnormality is primary, and secondary mitral valve prolapse when it is associated with the ventricle abnormality, sometimes seen in ischemic cardiomyopathy and sometimes seen in DCMP. So this is a video, upper video. It is showing a classical bileaflet mitral valve prolapse, which is termed in primary mitral valve prolapse. Then we can see the thickening of leaflets which are prolapsing towards the left atrium. While the another this transovascular echo video in the lower slide, it is showing basically papillary muscle rupture with anterior mitral leaflet prolapse. This is a secondary example of a secondary mitral valve prolapse. You can see the head of the papillary muscle prolapsing as a flail segment with the chordae attached into the left atrium. So this is how first we should divide the mitral valve prolapse. Secondly, the historically speaking, motion mode echocardiogram was used for mitral valve prolapse, in which we had to look at the CD line. This is the CD line. Here in the corresponding picture, we can see the CD line, and we had to see a hollow systolic displacement of at least 2 millimeter or 3 millimeter in late systole to give a diagnosis of mitral valve prolapse. But as we know, there is a single point measurement in motion mode, so this used to be missed, or more or say it was overdiagnosed by some experts also. So then came the 2D criteria. In 2D, mitral valve prolapse was defined as a single or bileaflet prolapse of at least 2 millimeter beyond the long axis annular plane with or without mitral thickening. This is the mitral annular plane which we are talking, and from here we measure the anterior and posterior. In this case, bileaflet prolapse was there, and where we measure the prolapsing depth. So this is the depth, and this is the case in which we have measured this. Is a bileaflet prolapse in a patient. Additional findings we can see there is an annular dilatation and also there is left atrial dilatation. So per se, it is not only the prolapse which we have to measure, we have to measure the annulars which gets dilated and flattened in mitral valve prolapse. Prolapse with thickening, that is, in this case, there are thickened leaflets. In the previous case, the leaflets were not as much thickened. It is termed as a classic prolapse, and the thickness of mitral leaflets are usually compared with the anterior aortic root diameter. And this thickness is to be reported because this thickness has also importance because this is classified as a myxomatous mitral valve prolapse, a classic prolapse. And there can be also non-classic prolapse in fibroelastin deficiency in elderly people. Now, which view? The view which has to be standardized in any lab is the standard parasternal long axis view. Why? Because the anterior posterior orientation is only seen in this view. Because of this view has to be settled because of the saddle shaped structure of the mitral annulus. And in apical view, as in this video, we see mitral annulus in a horizontal orientation, and only lowest points are seen, and we can overdiagnose mitral prolapse, as in this case, anterior mitral leaflet is appearing as prolapse. But this is not a true prolapse. True prolapse has to be commented only on the parasternal long axis view. The normal cooptation, as we know, is subannular, that is, it is towards the LV apex. But in some patients, we can see billowing of the leaflet, which is actually the superior motion of the leaflets. Billowing, normal billowing can be seen in the longer anterior mitral leaflets, as seen in this apical four-chamber view. But if posterior mitral leaflet is also billowing, as in this view, we can see billowing of both the leaflets, but they are not crossing the annular plane, then we can say this patient may exhibit mitral valve prolapse later on. So this may be the first stage we can notice, but this is not termed as mitral valve prolapse. This is not a classic prolapse. It's only the billowing of the leaflets which is seen, which may be associated with a trivial mitral regurgitation. Then further terms associated with mitral leaflets, with mitral valve prolapse, one is redundant leaflets. Redundancy is defined in parasternal short axis view, where the thicker leaflets encompass the LV cavity, more than 50% of the LV cavity. So there is basically a valve ventricle discordance in the LV cavity. Here we can see an example of this patient having a large valve covering most of the cavity of the left ventricle. These are the redundant leaflets in mitral valve prolapse. Then we have a flail segment, as earlier also shown, when the mitral valve leaflet tip is so much prolapsing, it is actually pointing towards the left atrial roof. This is sphere MR. Then moving on to transvisual echo. Transvisual echo is further much more beneficial in identifying the scallop prolapse, which scallop is involved, whether chordae involvement is there. As we can see in this patient, the classical prolapse of anterior mitral leaflet is more, and then the posterior mitral leaflets are thickened, and then we can change the view and we can find the which segment that is prolapsing segment is P1, A1, P2, A2, out of P3, A3, out of the anterior and posterior scallops, which one is actually prolapsing. And this can help us in defining the modality for repair. Both to the surgeon as well as in the era of mitral clip, transvisual echo is utmost important. Then there was this old study in Jack which showed that 3D transvisual echo has an accuracy rate of almost 92% compared to 2DT because it gives an en-fast imaging of mitral valve prolapse. So that we'll discuss later. Then quantification of mitral regurgitation in MVP. Single leaflet prolapse in mitral valve prolapse patients produces a jet which is directed contralaterally to the prolapsing segment. That is isolated, for example, isolated posterior leaflet will prolapse lead to anteriorly directed jet and vice versa. An anterior leaflet will cause a posteriorly directed jet. This causes usually a eccentric jet crawling along the left atrial wall and known as Quanda effect. These patients then it's a big pitfall in quantification of mitral regurgitation in such patients, and mostly it renders to imprecise MR quantification. As we can see in this example, this patient has a big MR jet hitting towards the left atrium. Is a bileaflet prolapse patient with thin leaflets, non-classical prolapse. But look at the left atrium in the long axis view, which is not much dilated. We use a single frame measurement using pizza diameter and we calculated the velocity time integral, and then we could find only an 8 ml regurgitant volume, and with mitral regurgitation ERO was 0.08 centimeter square. This mostly fits into mild. Look wise it looks like a moderate plus MR. Then we used color M mode. Color M mode is giving us that it is actually a mid to late systolic MR. So it is usually not a holosystolic MR in mitral valve prolapse. We should always keep in mind before commenting on the severity of MR in these patients that patient is having holosystolic mitral regurgitation or patient is having mid to late systolic MR. If patient is having mid to late systolic MR, the continuous wave Doppler will show a faint jet in the first part of systole, and from the mid to late systole only the jet will appear, and we will get a wrong velocity time integral. And single phase measurement like PISA, as in this case, are actually not helpful. Supportive parameters like LALV dilatations, they are more helpful in these patients. So this study again compared patients with holosystolic MR, those with less systolic MR yield, lower regurgitation volume, and lower ERO and jet areas. And jet area will be higher, but lower quantification measures. Then talking, as we discussed about three-dimensional echo, three-dimensional echo mitral valve, in three-dimensional echo mitral valve prolapse appear as a bulge. Now this is an atrial unfast view when the lapsing segment is appearing as a bulge or a convexity as a segment, and this appears brighter than the rest of the leaflets. Look at it, because it is closer to the probe and prolapsing towards the left atrium, and there may be associated coaptation defect as seen here by the arrow. There is a coaptation defect. So 3D is actually a view of a surgical view of the left atrium and fast. So and it is the recently recommended 3D quantifiable parameters include the leaflet area, the prolapse, number of prolapsing segments, as in this case the patient was having Barlow's, and Barlow's there is a multi-scallop prolapse we can see. Then we can see there is a this new software of 3D has even it has pointed out the 3D prolapsing volume. So this is very helpful in differentiating Barlow's disease, alveolar disease, and cutoff values have been there, like 1 millimeter differentiate MVP from normal subjects. The height is now a better choice in 3D echo. Then some pitfalls in assessment of left ventricle functions. Mitral valve prolapse patients over the years, they usually have LV dysfunction which is unexplained. So some theories and some hypotheses have been suggested. Among them, there is a dilatation and flattening of mitral annulus, as we seen in the earlier cases. The saddle-shaped anatomy is distorted. This leads to disorientation in the mitral annular contraction as an apparatus whole. And then there is also elongated caudal apparatus. The length of the caudal elongates, and this also hampers the full contraction by the ventricle. The LV volumes are reduced. The papillary muscle stretch and fibrosis also produces, as seen in this image, as a secondary changes in the annular geometry. And there is another problem is in these patients there is a prolapse volume. This is a space in end systole which is left over. Even we have tried to cover this. This is a space called as a dead pool. This is the height of the mitral prolapsing segment, which is not taken into account whenever we are measuring a Simpson type of ejection fraction. So these are the problems where pitfalls have to happen, and solutions are we have to take help of another modalities like speckle tracking in actually defining the LV functions in these patients. Then now the last few slides are we have made is on the arrhythmogenic or the risk of arrhythmia or arrhythmogenic mitral valve prolapse, which is not now a new entity. It is now a very well-defined entity. In this, the pathophysiology is such that we can follow the Padua hypothesis. This was given by the researchers at the Padua University, that if the patient is having mitral annular disjunction, which we will define in another slide, there is a curling motion of the mitral leaflets. There is abnormal click on a clinical examination. There is definite regional stretch as described in the posterior basal LV wall as well as the papillary muscle. This leads to ectopic beats and ectopic foci in the Purkinje fibers and mitral wall myxomatous degeneration and competence is there. So this video is from the patient with a typical mitral annular disjunction as seen with a bilifted prolapse in this posterior LV wall. So this patient came with history of pre-syncope. So measurement of the length of mitral annular disjunction is measured from LA wall, that is from the left atrial wall to the mitral wall posterior leaflet junction. And this cutoff used is in MRI as well as echo is 5 millimeter. So this here we can see the thinned out septum in systole in MRI, very beautifully expressed here. This leads to basically fibrosis of the LV wall and the source of periannular ectopic beats. And therefore, term as arrhythmogenic mitral valve prolapse is used for these patients. Another sign which is used in tissue Doppler is when we use tissue Doppler imaging on the lateral annulus in the same patient which we used, we get a instant spike in systole. This spike is the spike seen in the German helmet called used to known as Pickelhaube, and this spike is termed as Pickelhaube. This spike, the notion behind this spike is that there is altered myocardial deformation, which is due to tugging of the posterior medial papillary muscle in mid systole. As we can see nicely in mid systole, this is occurring mid to late systole by the myxomatous prolapsing, this myxomatous prolapsing segments, causing the adjacent posterior basal LV wall, which is pulled sharply towards the apex, and thus there is a spike. This spike is considered as a very important marker in arrhythmogenic mitral valve prolapse patients. Then speckle tracking echocardiogram. Speckle tracking echocardiogram is very easy to do nowadays. All the machines have this software in which we have to take all the three views, 4 chamber, apical 2 chamber, apical 3 chamber. These three views are suffice. They give us a bullseye chart of the peak systolic longitudinal strain, which here in the basal lateral wall is of course severely reduced, and also the mechanical dispersion, which we can say is very much disturbed. This also points out towards the ethnogenicity in the mitral valve prolapse patient. So overall, what we have learned today is that mitral valve prolapse as a term should not be restricted to only the leaflets. It is actually the whole mitral valve apparatus, annulus, papillary muscle, chordae, as well as the left ventricle. All the things are involved in the mitral valve prolapse patient who may enter into heart failure due to chronic traction on the papillary muscle chordae apparatus and causing LV dysfunction, or may end up into arrhythmogenic mitral valve prolapse as shown by the mitral annular disjunction. And many modalities have to be incorporated in the further evaluation of these patients, as seen tissue Doppler, speckle tracking, 3D echo, all are really helpful in deciding upon the best management of these cases. So overall, imaging sensitivity of CMR is more than transovasal echo and more than transthoracic. Mitral disjunction, as we discussed, should be reported on a standard format. Associated condition with MVP should be also reported, like mitral annular disjunction is more found in degenerative mitral valve than in fibroelastin deficiency, that is found in more than 70 years of adult patients. Then 3D extent is very important before surgical or percutaneous repair to identify the prolapsing scallops as well as the height and volume of the scallops and the flail segments. Then ventricular arrhythmia, as we have discussed, MRI is really helpful in identifying the fibrotic segments and periannular VPCs, which we can see. What are the future directions? There are many more. Mostly multimodality combination is important now in mitral valve prolapse, and they will be really helpful. And all the echo techniques also has to be incorporated. Thank you very much.
So please unmute yourself, Dr. Mani.
Yes, ma'am.
Dr. Mani, you have to unmute yourself.
I think Dr. Manivasagam, you have to unmute yourself. So let's move on to the next topic. If I can request Dr. Parashar to speak upon a very important topic on LVOT gradient, which has to be done on a regular basis. Dr. Parashar, over to you.
डॉक्टर पराशर सर, आपको भी अनम्यूट करना पड़ेगा.
Mute करा हुआ है.
वो
Now
कैसे?
can you hear?
Yes, sir.
Can
Now
you
it is
hear
good.
me?
Yes, sir.
So actually, we felt that this topic is important because an increased LVOT velocity can be found in many other conditions other than cardiomyopathy. And secondly, it is very important to precisely obtain a correct Doppler pattern and very carefully analyze it to reach a diagnosis, and you not be mistaken for any other Doppler signals. We'll just discuss some of the basic aspects also. Now, as you know, all of this is known to you that SCM is an left ventricular hypertrophy more than 15 millimeters in any segment in absence of other systemic disease. And there are various patterns of this. This is one of the classical ones showing an asymmetrical septal hypertrophy as compared to the inferior lateral wall, which is more than 1.5 as to 1. So this is one pattern of the thickening. This is another pattern where the inferior lateral wall is markedly thickened as compared to the interventricular septum, like a reverse ash, rather than this, which is the most commonest one. This is a very uncommon one, shows a massive thickening here. Then the third phenotype, you can see the mid-ventricular, where the thickening is in the mid segments of the LV, where the obliterate found in about 10% of the cases or so. And then next comes the apical hypertrophy, where the thickening is more than 15 millimeters in distally. So these are some of the normal phenotypes of the hypertrophic cardiomyopathy which we can get. This was one other case. This lady was mildly hypertensive, but fairly under intermittent control. And echo done elsewhere, they reported expected sigmoid septum thickening, otherwise normal. But when she came to us, as our policy is that any time we find any type of a significant LV hypertrophy, we always look for a mitral wall SAM. So here we found that there was a very marked thickening of the basal segment, which was more than 15 millimeters or so, obliterating the LVOT. And then we saw a SAM in the three-chamber view completely obliterating. And you see this is a same patient with this and the MR and the LVOT turbulence, and the gradient was about 60 to 65, which was missed because no information was gone, because don't get misdiagnosed, but this is an old age problem or so. So this can be another variant or so. Now, whenever we recalled a CW Doppler in apical 3 or 5 chamber views, and what we get is an apical is a sort of a correct, according to the modified Bernoulli equation, we get an immediate apical views or so, and you get the sectors, the segments, and the velocities. The definitions have been known to you, but we just to revise it. A labile one is a spontaneous appearance and disappearance of obstruction. Latent is gradients that only appear with provocation. Dynamic is it varies with physiological situations and loading conditions. So these are the three common types of a gradient seen, and they can vary from day to day or even hour to hour basis, may vary even after heavy meal or alcohol. Hence, values may differ in different studies, so you should not force yourself to give a report which matching the previous one, where it can be different also. So this is the most common type of a gradient with this variety also. Then you see, all of you know the normal anatomy of the LVOT. In any view, this is the area between the anterior mitral leaflet and the interventricular septum is the LVOT. That is the area from where the blood goes out of the LV, hence is known as LVOT. And this is what we see in a hypertrophic cardiomyopathy, again known to you well, that there is a marked systolic anterior motion of the anterior mitral leaflet with a massive thickening of the interventricular septum, leading to a narrowed LVOT because of these two mechanisms. So, and you can see this is like you see a zoomed view, parasternal long axis view, and if you are careful, you can see a systolic anterior motion of the anterior mitral leaflet, which is obliterating the LVOT. Clearly, you can see. And you can also see this is the classical SAM, and this is LVOT, what we showed you in one of the diagrammatic representation, and completely obliterating the LVOT, and it's SAM plus a thickening of the interventricular septum. And now coming to the gradients, which is important, as you know, the main component of LVOT gradient, which has got a significant prognostic information, are a SAM plus ASH. Now there are various mechanisms for SAM which we need not go into detail, various abnormalities of the mitral leaflet, a malpositioning of the papillary muscle, so the time doesn't permit us to go to the various mechanisms. But what is significant is an obstructive gradient is one where the resting gradient is more than 30 millimeters of mercury. A provocable gradient is the one in which the hemodynamically significant gradient can be obtained by provocation, and more than 50 millimeter Hg is supposed to be a therapeutic target for various management also, found in about 30 to 35% cases. Latent provocable gradient, that is resting, is less than 30, but on provocation it is more than 30. And non-obstructive, that it is less than 30, and even after provocation it is less than 30. So these are the important ones: obstructive, provocable, latent provocable, and the non-obstructive. Now this just to show you that this is a representation, this is a typical dagger shaped LVOT, in which initially there is a convex because there is an unimpeded blood flow going. So there is a convexity toward this side, and then there is a sudden acceleration of the flow and giving rise to a late peaking and a dagger shaped structure. So this should not be confused with a MR jet. This MR is usually a very high velocity flow, as compared to the LVOT velocity, it is usually in mid and late systole and more like a parabolic sort of a thing, right from onset to mid. So one should not confuse between the two. And this is like one of our cases. You see, there is an initial convexity and then there is a concavity giving to a dagger shape in late systole, and the gradient was about 113. So this is how a gradient is recorded from the LVOT or wherever it is. So this is a typical pattern of the velocity which is seen. Now the provocative measures, remember they vary with heart rate, blood pressure, volume status, and some of the factors which increase the LVOT obstruction is a decreased LV volume because they decrease the preload. When there is a decreased filling of the left ventricle, it becomes smaller. It tends to compensate by an increased cardiac output, an increase in heart rate. So these two factors lead to a providing an LVOT obstruction, contractage, you know very well, and a decreased afterload. When you decrease an afterload, there is a less resistance to the flow of the blood. Again, a cardiac output is increased or increased. The gradient is increased. So mainly you see it is a preload or a LV volume decrease which produces an obstruction, and an increased contractility and a decreased afterload which promotes an increased flow. So now coming to them, we find that in most of our clinical practice, these three have become very sort of a commonly used. We have not been able to use this because we have got a good information from these three. For example, you see this is one of the patient who could not do a Valsalva. His resting was 18, and when we gave him sorbitrate, a sublingually, we go on recording after sorbitrate till we get a maximum gradient or a SAM or so, and after sorbitrate it came up to 94. So if we had only relied on this, we would have missed some very important information. So once you are suspecting a hokum, you give a sorbitrate and you go on recording, and here you see a typical dagger shaped recording late systole, and it went up to about 94. So that is one advantage of doing with a sorbitrate. But now we are doing a more of a Valsalva. Again, you see, it was about 40, and giving Valsalva for about 10 seconds, which reduces the preload. So the main action of the Valsalva is it reduces the preload. We should tell the patient initially how to do Valsalva, and then sometimes when the patient does a Valsalva, your Doppler sample volume or your CW become deranged. So you set your Doppler and then ask him to do Valsalva for about 8 to 10 seconds. And here you see it went up to 108. Now this is a posteriorly directed MR jet, so this cannot be confused with an MR jet or here unless it was an anteriorly directed. So you see this is how the two provocative matters helped us in getting a significant gradient. Then this is latent provocable. Then with the LVOT was about 21 or 20, and after Valsalva it came to about 45. So this was below 30 in the resting state, and then went to provoked, it went to more than 30. This is known as the latent provocable. Now, coming to the postprandial, which is very important. Now, this was a patient, again, we did about 20 or so. Again, he could not do a Valsalva very well. So the patient said, can he come after lunch? When he came after lunch, we immediately did a repeat echo, and from 20 it went up to 65. So once you are doubting also, ask the patient to eat something, and you suddenly see a significant increase in the gradient from the resting or a fasting state as compared to the meals. And the reason is that following a meal as per the normal mechanism, there is a splenic and mesenteric vasodilatation. they lead to a decreased systemic vascular resistance, and this leads to an activation of the sympathetic system and increased contractility in heart rate, and they lead to increased LVOT gradient. So these are some of the mechanisms. And in one of the J's October 2024, they said that a postprandial echo unmasked LVOT obstruction in almost one-third of patients with presumed non-obstructive SCM. Half of the patients treated with invasive or enhanced therapeutics only had a postprandial LVOT obstruction. Before eating, before resting, exercise echo is a powerful tool in SCM. So their conclusion was it is a very simple and very effective approach to unpass the latent dynamic obstruction in daily clinical practice. So one should always use it whenever possible to see the gradients if they are not masked or so. And you know, a long time back, they used to initiate a ventricular ectopic beat in the cath lab to see for the gradients for the initial activity. So this was one of the cases in which with the patient was having ectopic, we saw that the initial gradient was 105 just out of clinical interest, and after an ectopic beat, it went up to 170. So once the patient has an ectopic beat, take advantage of this by using a gradient, and you see there was a significant increase in the gradient. Now coming to the mid LV, now you see this is a mid LV type of obstruction, and also there was some sort of thinning and akinesia of the apex, suggestive of possibly a aneurysm or something. And here you see a turbulence at the level of the mid LV, and you put a Doppler beam here, and you get a good Doppler. We put a high path PRF Doppler, and you see you get a gradient which is a narrow peaking type. It is sort of known as ice pick type of a gradient, and you put it at this thing, and you see that there is a good Doppler envelope like an ice pick giving a 56 Hg. So this is another. Now this is known as what we have seen sometimes. Now initially it was thought that this lobster claw deformity, which we had in one of our cases of a mid LV gradient and apical one, was supposed to be specific for only this group of cases. But subsequently, it has been shown that this can be found in anywhere there is a significant obstruction, especially more than 60 millimeters of mercury. So even it can be found in LVOT also, and not only specific for a mid LV. And this is what we found, that you see this is upright. If you invert it, it is like this. This is sort of an early systolic, a late systolic peak gradient. Then there is this cessation of flow, and then there is a when the diastole starts, the obstruction becomes less, and the flow comes toward the LVOT, and this type of a pattern is seen. So always see this is a very, you can see the mechanism for them, but this is a classical lobster claw deformity what we found in some of our cases, and do not ignore it. It can be found anywhere at any obstruction. Now this patient had most likely a multiple obstruction. You see there is an obstruction at the mid-ventricular level, and also there is a SAM here. There is a partial SAM here, and that was without sort of a provocation. So these multiples can be sometimes seen, and you see this is one of our the same J's. You see two peaks. One peak is from the LVOT, and one peak is at the MV. So always, whenever there are two peaks, you should always see that they carefully analyze them. And this is just to show how to differentiate from MR. But when I see here, you see this is an MR with the late, mid and late peaking, a gradual parabolic, and this is just a sharp, a sort of a jet because of a mu peaking. Now this was considered, this is one of our cases by Hardeep Grewal. You see, again you see there is a multitude distinct Doppler signals. This is sort of a late Doppler from the LVOT. Then there's another signal coming, which is from the obstruction, and you see this signal has got two peaks, one early diastole, this diastole, and this early diastole, and this early diastole is also seen here. So this is also like a claw deformity, but showing a multiple peaks or so. So never forget or never ignore these multiple peaks and analyze them very carefully. Now, remember this MR also is usually dynamic, and anything which increases the LVOT gradient also increases the MR value. That is usually of a posterior directed because of some of the mechanisms of the SAM also, posteriorly directed also. But whenever there is an obstruction, when there is a disease of the mitral wall, it can be anterior also. For example, this patient, one of our patients has a vegetations in relation to the anterior mitral leaflet. So you see multiple vegetations and with a SAM and a thickening. So because of this abnormality, the MR was more or less anterior. This can always be confused with an LVOT velocity, so one has to use various imaging planes, off-axis planes, remove the color depth width or so. So be very careful so you don't record the mitral velocity as compared to the, but just to show that a intrinsic disease of the mitral wall can lead to anteriorly oriented gradients. So there are many other causes of LVOT gradient, but we had about 2-3 cases of a discrete subaortic stenosis, and all of them are based on the same thing: LV activity, hyperkinesia, the BP, tachycardia. All of them are based on this. But we had two cases or three cases. One of them, the patient had a massive hypertrophy. This patient was referred as a case of hypertrophic obstructive cardiomyopathy. So our policy is that every case of a HOCM, we always see the subvalvular area. We never miss the subvalvular area. So always we see for a SAM and always see for a subvalvular area here. And here you see you see on a transesophageal echo, you see there was a subaortic membrane here, and you see this was also suggested on a 2D echo, and there was a turbulence starting from the much lower than the wall, and this led to the giving the diagnosis of a subaortic stenosis. And this is the pseudo SAM which is characteristic of these cases. So this pseudo SAM is dependent on the vigorous contractility of the posterior wall. So this SAM is in relation with the posterior wall contractility. It's not there. So when the posterior wall contracts vigorously, it pulls the anterior mitral lever. So it is always in the late systole, while in a classical SAM starts from the mid to late, and it got nothing to do with the posterior wall contractility. So this is an independent thing, and this is found is known as pseudo SAM due to a vigorous contractility, and it coincides with this. So this is known as a pseudo SAM. And of course, this patient from a right parasternal window showed a critical subaortic stenosis. And this sometimes one should not confuse with aortic stenosis. In an aortic stenosis, you can always see the jet which starting from here to going there. When the velocity increases, the jet acceleration decreases. It can be either early systole or late, while this is a classical obstructive cardiomyopathy because high pressure gradients also. And this is so too, you can see an aortic stenosis, which cannot be confused in any case. You see a thickening of the calcification of the aortic cuff and many other anatomical features plus this. So take home points are: Doppler allows for evaluation of the LVOT, mid-ventricular and multi-level obstruction. A difference of findings on separate occasions is not unusual, and we must have a careful analysis of the Doppler signal is vital. Always record heart rate, blood pressure, and time of study every case, because many of the findings will depend upon this. Relying solely on the presence of LVOT gradients less than 30 millimeters at rest can lead to misclassification of patients as being non-obstructive. So the provocative measures may be necessary to unmask dynamic LVOT obstruction. Decreases in preload, decreases in afterload, and increase in the contractility promote obstruction. So obstruction with SCM is not only dynamic but extremely variable and may fluctuate in day-to-day basis. So do not force yourself to match your report with the previous study or ask for who had it done and at this, so because it can vary also. So thank you very much.
Thank you so much, Dr. Parashar.
Thank you, sir.
Thank you. So we have a couple of questions. Can I start?
Yes, sir.
Yeah, this is for Dr. Nitin Burkule. Yeah, the first says as the X-ray passes to the box and is captured by the detector on the other side, one can understand that series of detectors in one slice will provide lateral resolution. But what about the axial resolution? How is it provided?
Yeah, I think we will be discussing how the image is formed in the next lecture, and this particular thought process is from the ultrasound that you're talking about the axial and lateral resolution. But CT is a technique necessarily captures the image in 3 dimension. And interestingly, the X, Y, and Z direction, you have the same resolution, and the smallest cube voxel that you get. So a highest spatial resolution that you get is only CT. And so there is nothing like an actual resolution here. Okay, it's the 3D data, the imaging data is acquired in 3D itself because you're rotating the gantry all around it. So you are actually getting the attenuation data from all the sides in multiple projections. Okay, and then you reconstruct the image. Okay, so it is necessarily so among all the four imaging modalities, the echo, MRI, nuclear, and CT has the highest spatial resolution. Okay, and the most important thing is the image that you see is isotropic. That means every voxel is perfect cuboid. You go X, Y, Z direction, you have got the same resolution. Unlike our 3D echo, where we have the best axial resolution, reduced lateral resolution, and worst resolution in the elevation side. Okay, so because we really don't create a true cuboid voxel there. So that is the way it is. So everything we should know how the images are acquired so that we can look at the images and get the best out of it.
Yeah, thank you. This is for Dr. Rohit. For diagnosing MVP, is it not necessary to have the coaptation point going below the annular plane?
Yes, sir. This is the definition criteria. The coaptation point should go beyond the annular plane, and then only we term it as mitral valve prolapse. Otherwise, we just say it is a billowing leaflet if it is going towards the L.
Correct. So second one, what is the incidence of MAD in non-MVP patient? And how many patients have tricuspid valve dysfunction along with MVPs?
So, okay, mitral valve prolapse with tricuspid valve prolapse is found in combination 5% of the patient, but there are variable study regarding mitral annular disjunction. So actually, there is a meta-analysis in which they have found in 11 studies it was variably reported. But in nutshell, they told that 25 to 30% of bileaflet prolapse can have mitral annular disjunction. In general population, they say it is less than 4% mitral annular disjunction.
Correct. So this is for Dr. Parashar. How can we differentiate with only maximum gradient? What is the relationship between MR maximum gradient and LVOT maximum gradient and patient systolic blood pressure? I think
Yeah, there is definitely, say, some persons have tried to calculate the LVOT gradient with recording of the systolic blood pressure, taking the gradient of the LVOT or the MR, adding LA pressure also. But the main thing is that the MR gradient, if MR velocity is usually much higher as compared to the LVOT velocity. And it is said that whenever you get an LVOT gradient of about more than 100 or so, try carefully to rule out MR or so. So, and the pattern of the Doppler envelope as you have seen, and the velocity pattern, and the peaking in mid and late systole, that helps us to differentiate. And in one of the slides I showed you, an MR together with the LVOT gradient, and both had separate peaks. So it has to be a separate peak, and then the pattern of the Doppler envelope and the velocity can help us in differentiating from MR from the LVOT velocity, which is
And you have
typically
shown,
dagger shaped.
yeah, we have shown nice examples in this. So next one, during dobutamine stress test, do we have to give clinical importance to dynamic LVOT obstruction?
Say it is one of the causes of this, but because it has got less diagnostic value, because you are creating more of a tachycardia, positive inotropic state or so. So that is why in any exercise study, they have not used dobutamine, because they have used a treadmill, they have used other thing, but they have not used dobutamine because its diagnostic value may be less in initiating a gradient or so. So most of these studies have been all these exercise tests which have been reported done very much in Western literature. They don't give dobutamine, they give only the exercise ECG. And as I told you, in our day-to-day practice, these three methods have been very useful for us. Dobutamine have been reported as a case as can cause uh, SAM also, but because of its physiological properties, we are not using it that much also.
Great. I think that was an amazing discussion. I think all questions have been solved. Over to you, Dr. Mani Vasakam. Final remarks.
Yes. So one question to Rohit. They said that there is true and false MAD. From one is during systole and the true is both during systole and diastole. Is it true?
Say this
No, no.
pseudo SAM. Acha,
No. This is regarding mitral annular disjunction. True
Okay.
mitral.
True mitral ulnar disjunction has to be reported only in end systole when there is a more than 5 millimeter difference from the annulus to the posterior basal wall. In diastole, if you have a diastolic as well as systolic mitral ulnar disjunction, that is usually pseudo mitral ulnar disjunction.
I
That
see.
cannot be attributed as a arrhythmic substrate.
No. I
Okay.
think let me
That is
change it. So don't take it wrong, Rohit. So I think
No.
this work comes from Francisco Felletra. There are two publications, 22 and 25. So what they have said that it's a big analysis of 600 patients. He says that the true match should be in both systole and diastole. But if it is only in systole, it is a pseudo match. So it actually reversed it. So I think the arrhythmogenic
correct.
potential is there for true MAD, but he emphasizes very clearly that it has to be seen in both systole and diastole. So this paper is from Felletra, Francisco
Yes.
Felletra, in 22 and 25, two papers.
611 patients they had studied. Yes, you're right.
Very important question, right, sir?
Yes.
Okay. Thank you. If there is no more questions, we will wind up this session, sir. All of them, all of you have done well, and we'll close this session, sir. Thank you.
Thank you, sir.
Thank you so much.
Simi and Manish Bansal.